Okay, so skin changes. We've all seen this. But one of the basic things is to always do your edema assessment, right? Just part of comprehensive skin assessment. And we want to look for pitting and rebound. And we basically grade it according to the depth and to the time it takes to rebound. And this is a really classic example. So here's a lymphodematous limb with a lot of those fibrotic changes we talked about. And you can see with this finger, she's trying to pit that tissue. It's not going anywhere. It's kind of like pushing on a candle or pushing on tree bark. It's just not going to go anywhere. But up here, it's still kind of soft and pitting. And so the fibrotic changes haven't occurred up here as well. So we want to really note, like, how much pitting do we do now? Now, you're not going to sit there and measure this, right? It's clinical judgment. But we can use pitting scales because it's always good to try to quantify our information when we're doing our tests and measures. And so with skin changes, we know we see the most common forms of edema we see in clinical practice are venous insufficiency, lymphedema, lipedema, which we'll talk about, and congestive heart failure. And so it's very important that we don't always, we often look, obviously, at our patients and visually assess them, but we have to use all of our senses. We really have to feel and palpate those tissues too to pick up those subtle changes, whether it's tissue consistency or texture. We have to really look, we have to talk and ask questions, get a good history. One of the side effects of doing wound care, of course, we have to smell, and we really need to actively listen, because if we really listen to our patients, they will tell us what's wrong. They may not have the medical terms to tell us, but they always know what's wrong with them. And so we need to really listen to be able to glean some of those clues. Okay, so with the CVI, we know typically with traditional venous insufficiency, that early on with venous hypertension, it leads to that watery, low-protein watery edema. Until there's dysfunction of the lymphatic system, that's when it converts to high-protein edema and a true lymphedema. We may, with classic venous insufficiency, you might not have a stemmer sign. It might be negative initially until there's more fibrotic changes that persist. Typically with CVI, it's going to be symmetrical, but patients with lymphedema, this is one of the telltale signs that it's lymphedema, if it's bilateral, it's always asymmetrical. And this is a differential diagnosis between lymphedema and lipedema. So if it's bilateral lower extremity lymphedema, it will be asymmetrical. Now, sometimes it's really hard to tell looking at your patients that it's asymmetrical. But if you take your circumferential girth measurements, one limb will always be more involved than the other. Lipedema, which we'll talk about later, is symmetrical. And it's an abnormality of adipose tissue, which we'll talk about. But that if you're trying to decide, well, what's going on with this patient, look for symmetry.